Okay. Where's my UAPD folks? Okay. Okay. Thank you, Mr. Chair, Senators. SB 877 will require the California Department of Public Health to reestablish and maintain the California Electronic Violent Death Reporting System. Our CalEviters, I guess. This reporting system is based off the National Violent Death Reporting System, which is a state-based surveillance system. Although this is a very useful tool, the national database is only as good as the data the individual states provide, and currently California is not a participant. However, this was not always the case. From 2005 to 2010, California contributed to this national database. However, due to the lack of resources, the department wasn't able to qualify for federal funding needed to maintain the system. However, it's important we bring back our state electronic violent death reporting system. Violence is a threat to public health that can be prevented. SB 877 is the first step toward that prevention. With proper data, we can understand what is driving violent deaths and address the root of the problem. SB 877 will let us make smarter decisions that we can keep the public safe. There's currently no opposition to the bill, and I respectfully ask for your aye vote. Thank you, and I have witnesses in support.
Thank you. Those in support, state your name and position.
Doug Chiappetta, Union of American Physicians and Dentists with AFSCME. I have with me our board president, Dr. Bussey. We are one of the co-sponsors of this legislation. We supported it when it was AB 540, when Dr. Pan was an assemblyman. We think it's a strong piece of legislation as it mandates counties to collect data on violent death, and we urge your strong support.
Dr. Bussey, I totally concur. Knowledge is power, and we need these statistics.
Mr. Chair, members of the committee, Brian Allison on behalf of the American Federation of State, County, and Municipal Employees. First, want to commend the committee consultant on the exceptional analysis. This bill, as was previously stated by our folks at UAPD, is a matter of good public policy. We need to make sure that we have all the information to help reduce the instances of violent deaths in our communities, and also making sure that we can begin to stem the tide on these things by ensuring that, as they mentioned, we have the information. But this is a matter also of being able to address these things in the future. If we don't have the information, there's no way for us to possibly begin to address these issues. So for those reasons and for those that were previously stated, I'd like to ask for your support on the bill.
Anyone else in support?
Mike Gonzalez, Chair of the Greater Sacramento Area Chapter of the American Foundation for Suicide Prevention, and also representing the American Foundation of Suicide Prevention nationally. We strongly support passage of this bill.
Lady Vaughan, representing American Academy of Pediatrics. We are in support.
Kieran Savage, National Alliance on Mental Illness of California, in support.
Anyone else in support? Senator Wolk, you had a question, comment?
No.
Okay, we are.
Comment.
Comment. Okay, first let's do the opposition. Any opposition? What comment then? Senator Wolk?
I'd like to move the bill. I think it's excellent. We need to move forward and get this data and move forward from there with good policy. Thank you.
Thank you. Anyone else? Any other comment? Seeing no other comment, would you like to close?
Violent death is something that is preventable. If we have the data, we can do the research. I know that Senator Wolkoff authored a bill to look at gun violence research, which unfortunately is also one of the major leading causes of violent death. That data is essential to allow us to figure out how do we prevent and develop the kind of policies that are effective toward that, and I respectfully ask for an aye vote. Thank you.
Okay, we're in item number 1, SB 877, due pass-through appropriations. Call the members.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall. Mitchell. Monning.
Aye.
Monning, aye. Nielsen. Pan.
Aye.
Pan, aye. Roth.
Aye.
Roth, aye. Wolk.
Aye.
Wolk, aye.
5-0. We'll place that bill on call. We're in item number 7, SB 1095, newborn screening program.
Well, thank you again. Oops. Set that up.
ready?
Okay, thank you again, Senator, Mr. Chair, Senators. Today I am presenting Senate Bill 1095, which ensures that California implements newborn screening tests that have been recommended by the U.S. Department of Health and Human Services after a rigorous scientific review of the benefits of the screening test. Newborn screening for rare diseases is a critical, cost-effective public health intervention that may prevent the progression of diseases that may lead to permanent physical or mental disability if not diagnosed and treated shortly after birth. Early treatment saves and improves children's and families' lives and can reduce medical costs by eliminating or ameliorating the often devastating consequences of rare and treatable diseases, particularly metabolic diseases. Most rare diseases, about 83%, afflict fewer than 6,000 Americans. And because of the relative rarity, most patients are not diagnosed for roughly 7 years, and only after generally catastrophic and often irreversible symptoms manifest themselves. For example, adrenoleukodystrophy, or ALD, is often initially misdiagnosed as much more common conditions, such as ADHD, leading to delays in effective treatment and continued progression of the disease. SB 1095 would ensure that California adopt the newborn screening recommendations made by the Advisory Committee on Heritable Disorders in Newborns and Children, a federal committee composed of newborn screening experts and geneticists working under the auspices of the U.S. Department of Health and Human Services. After conducting a rigorous scientific analysis, the committee recommends the conditions that should be screened to the Secretary of the Health and Human Services. Those recommendations are then listed on the recommended uniform screening panel, and the Secretary of Health and Human Services has 120 days to accept or reject the scientific panel's recommendation. This exhaustive federal process is robust, science-based, and actually can take from months to years in conducting its analysis. There's no need for California to replicate the structured evidence-based committee process. Among the criteria evaluated by the committee are, one, that the disease can be identified at 24 to 48 hours after birth and is not otherwise detected by the doctor's clinical exam. Two, that the screening test itself must be cost-effective and specific and sensitive, efficient, implementable, and reliable. And three, that early detection can lead to timely intervention and a viable, effective treatment. Early treatment can prevent irreversible complications of disease, providing cost savings to the state and ensuring better health outcomes for babies born in California. I would like to recognize the concerns that have been expressed by the California Hospital Association and inform the committee that we are working with CHA to resolve those concerns. Today I have with me Sabrina Lowe-Dumond, who's a parent of a child with Pompe disease, Mark Dant, MPS 1 parent and executive director of the National MPS Society, and Dean Schur, MLD parent and president, founder of the MLD Foundation, and founder of the Newborn Screening RUSP Roundtable, and an MLD parent, to share their personal stories and answer any technical questions. Thank you.
Mr. Chairman, members, Mike Carpenter on behalf of the Every Life Foundation for Rare Diseases. This is a group that advocates on behalf of children and their families with rare diseases. I just want to add to the comment that we just heard from Dr. Pan that also we have Julia Jenkins, who's their executive director, here to answer any technical questions we may have. But as you're about to hear from these parents, a delay in screening and diagnosis can have catastrophic and often lifetime and irreversible consequences for these children.
Thank you. Please proceed. State your name and your position.
Good afternoon. My name is Sabrina Lowe-Dumond. I live in Orange County, California. My son, Zach, suffers from a rare form of muscular dystrophy called Pompe disease. Pompe is a genetic muscle-wasting condition. Left untreated, it leads to heart problems, severe muscle weakness, compromised breathing, and eventually death. Damage from Pompe is unforgiving, and left untreated, it cannot be reversed. At age 8, we saw signs of general muscle weakness in Zach's legs during Little League and swimming lessons, and we just chalked it up to him being not very athletic. By age 10, he was sitting up to sleep because he couldn't get enough air laying down. His neck muscles could no longer support the weight of his head, and he was stumbling, often showing signs of difficulty with core strength. For an additional 2 anguished years, we went from specialist to specialist trying to find out what was wrong with him. Zach had to endure nerve connection tests, sleep studies, blood labs, muscle biopsies, skin biopsies, surgeries, MRIs, and a series of other medical conditions. because doctors couldn't figure out what was wrong. We were challenged with misdiagnoses, hospitalizations, and medical fees. It was extremely difficult on our entire family, but it was the hardest on Zach. The worst part is that during the time it took us to get diagnosed, Zach could have been receiving the FDA-approved enzyme replacement therapy, Myozyme. Zach was finally diagnosed at age 12. However, the muscle damage was already too severe in his quads, diaphragm, and core. He will never recover that muscle back. Regardless of treatment, if Zach had started enzyme replacement therapy at the first sign of muscle weakness, there's no telling what kind of child I would be raising today. Maybe he wouldn't have to use a machine to breathe every night when he goes to bed, or need a feeding tube to get protein 24/7. Maybe he wouldn't have needed the extensive and invasive scoliosis surgery he had to embed 22-inch titanium rods in his back because his muscles couldn't support the growth of his spine. Maybe he wouldn't need a cough assist machine or a nebulizer to breathe. Maybe he wouldn't need to take medication for early onset osteoporosis. And maybe he wouldn't need antidepressants for having to deal with a lifetime of limitations to having a chronic progressive disease. Had there been newborn screening in place for Pompe disease, all of this could have been avoided. This legislation would spare parents, future parents, endless heartbreak, unnecessary medical costs, and delays in diagnosis. It would give their child a shot at a normal life. I beg of you to support SB 1095, and I thank you for your time.
Thank you.
My name is Mark Dant. I am the Executive Director of the National MPS Society and also the parent of Ryan Dant, who was born with MPS 1 28 years ago today. MPS 1, like Pompe, is a terminal illness if left untreated. Ryan is now the longest treated person in the world on the only drug available to treat MPS 1. A drug, I might add, developed and manufactured right here in California. As Ryan's father, I can speak firsthand to the slow but devastating change we witnessed our son undergo prior to treatment. Ryan was diagnosed with MPS 1 after his pediatrician noticed his liver and spleen were way too large. But at the age of 4, Ryan was able to run with nearly the same grace and ease as most 4-year-olds. But by 8, he had to quit his favorite sport, baseball. We watched as the disease took over his body. We watched our son at 3 dress himself, but by 8 could not. By 9, Ryan had undergone 5 surgeries to try to correct the damage that MPS had started. On February 13th, 1998, at the Harbor UCLA Medical Center in Torrance, 8 weeks before his 10th birthday, Ryan received his first infusion of the drug that would forever change his life. Within a year, Ryan's health improved to the point that he once again played baseball. Ryan had stopped talking about his future because he knew there wasn't one. But Ryan, after 1 year of treatment, started talking about what he was going to do tomorrow, and that was huge for us. Our son's journey pales in comparison to the often lengthy quest parents undergo to fight and find for diagnosis. Crystal Gonzalez from Chula Vista, California's diagnostic odyssey is sadly not an isolated story. Crystal's mother, Linda, took her to a pediatrician when she was 8 years old because she had not yet received an answer to why Crystal was developing so differently than any of her schoolmates. Her pediatrician suggested she take her to a rheumatologist because of her stiff fingers and short stature. The rheumatologist treated her for arthritis. After about 2 years with no improvement, the rheumatologist sent her to a geneticist who diagnosed her with Noonan syndrome and shortly thereafter started her on the protocol, which was chemo. Crystal's mom noticed that all of her hair fell out and she was nauseous nearly every day. She was being treated for a disease she did not have. Within 2 more years, she went to another physician who finally diagnosed her with MPS 1. And within a few weeks, she started on the drug that Ryan started so many years ago, the drug that was approved 7 years before. Crystal's mom notices today that she's much more active, much more happy, and looks forward to tomorrow as well. Crystal's story and the many like them speak to the importance of the earliest possible diagnosis for rare diseases like MPS. Frankly, many physicians won't ever see a child like Crystal or Ryan because it is rare, which makes the likelihood of early diagnosis even more remote. The absolute key to improving the health and changing the life journey for someone born with MPS is in newborn screening. We cannot change what Crystal and Ryan lost all those years without treatment, but what we can do is keep other parents from watching their children suffer day after day as they seek the right diagnosis. Today, I urge you, support Senate Bill 1095 for children like Ryan and Crystal across the state. We thank you.
No red light. There we go. Good afternoon. My name is Dean Sir. I'm a rare disease dad. I have two girls with metachromatic leukodystrophy, a rare lysosomal neurometabolic disease. Darcy, my 10-year-old, passed away at the age of, at age of 10. My 35-year-old that you see here beside her, Lindy, is terminally ill with this disease. Newborn screening won't save my daughter, and I acknowledge that. However, the impact of not having a newborn screen has been tremendous on our family and those around us. Lindy's issues started at age 8. We went through about a 6-year diagnostic odyssey. In the middle of that diagnostic odyssey, at the age of 12, I had to take Lindy out of our house because she was just out of control. She couldn't control herself. We ended up in the hallway of a courthouse for a criminal issue, and literally we're sitting on the bench out in the hallway when we got her diagnosis, and her diagnosis was a genetic disease. The state said, okay, it's not a criminal issue, it's a medical issue, go home, take care of it. And we, luckily, I guess, we said no. We said, you took her away from us, you're going to keep helping us through this process. And we continued on. Lindy is now 35, and in spite of the great smile on her face there, she's in a wheelchair, she's in diapers, we have to feed her, we have to take care of all of her daily care. And this is a story that's repeated again and again and again. There's a young man by the name of Guy Davies, who 10:30 last night I found out had passed away from MLD. He's from Sierra Madre, and his one wish that he got granted was to have a day with Sierra Madre Fire Department. He was only 2.5. He has the form of MLD that most patients have, which is the late infantile form. Their symptoms show up at 12 to 18 months. This young man was diagnosed at 2.5, and he died 2 months later. If we had had newborn screening, this young man would have been treated and he would be alive today. My other role is that of the MLD Foundation. When we found out about this disease in our kids, we knew that connecting parents and supporting parents was really important, and we came to discover the importance of policy and, of course, the importance of advancing research. And so we do work on behalf of MLD, both here in the U.S., and, of course, serving the patients in California, as well as internationally. And one of our key issues is also up at the high rare disease level, and that's newborn screening. And I might point out that newborn screening is not a rare disease issue. There are common diseases and conditions, hearing, for example, that's part of the screening panel right now. My experience, however, is in the newborn screening area. We started from the MLD Foundation an initiative called the RUSP Roundtable to further improve the RUSP, and I'm going to talk about that in just a moment, but there's some issues, and it can continue to be improved as well in terms of how it addresses and the thoroughness and all of the approaches can be continually improved as time goes on. I want to just highlight, fill in a couple blanks that Dr. Pan skimmed over with the integrity and the rigorousness of the RUSP itself and that process. He talked about that you have to have a net benefit for the screening, that you have to have a reliable screen, a therapy, and a diagnostic test. There's another key component of the evaluation and the review process for that RUSP, and that is that the test has to be implementable by the states. And the state has representatives on that committee through the APHL, the Association of Public Health Laboratories, and some direct representation that includes some folks from California. And efficiency, throughput, access to equipment, a defined follow-up strategy. So if you're identified as having a potential for one of these diseases, what happens? And then practical implementation issues are all part of that RUSP proposal. So the RUSP is a very, very rigorous, intense process, and it is what is the core of what we're asking for you to support in Bill 1095. California, thank you. You are a leader in newborn screening. There are 34 diseases on the RUSP right now. California is screening for 52. There's a couple of them on the RUSP that you're not screening for yet, but you're working on those. But you are a leader, and we hope that you will continue to lead in this policy area, and we urge you to support 1095.
Thank you. I will ask anyone else to only state your name and position. We've allowed 6 minutes. We've doubled that with this panel. If there is opposition, we're going to give the opposition the same amount of time. Please state your name and position.
Mr. Chair and members, Betsy Armstrong on behalf of the County Health Executives Association, representing local health departments, and urge your support.
Hi, I'm Karen Ratto, and I'm also an MPS 1 parent, and it took 2 years to get my daughter's diagnosis, so I ask you please to support this bill.
Mr. Chair and members, Maureen Higgins on behalf of Biocom in support of the bill.
Justin Garrett with the March of Dimes in support.
Lydia Bourne, American Academy of Pediatrics, in support.
Brian Allison, American Federation of State, County, Municipal Employees, in support.
Thank you. Opposition? We can make room for the opposition. In all fairness,
I'll make it brief, Mr. Chair. Thank you. Alex Hawthorne on behalf of the California Hospital Association. We are not opposed to the bill. We did raise a few small technical concerns. Thank you for the commitment to working with us. And I'll just close by saying that we strongly support the newborn screening program and are proud of the role we play in it. Thank you.
Thank you. Anyone else? Opposition? Questions, comments from any of the members? Yes, Senator Monning.
Just briefly, thank you, Mr. Chair. Just want to thank the author and all the advocates who are here today. I had the honor of carrying a resolution in the Senate recognizing Rare Disease Day. It's now in our state assembly, and what you're doing by your presence here today is helping raise our awareness and hopefully informing our policy. So thank you, and I'd be glad to move the bill at the appropriate time.
Sure. Yeah, any other questions? Seeing none, we have a motion by Senator Monning. Would you like to close?
Thank you. As a pediatrician, I've devoted my career to helping children on the path to a healthy life, and I've witnessed firsthand how newborn screening can prevent permanent disability and save lives. I respectfully ask for your aye vote. Thank you.
Thank you. We've got item number 7, SB 1095. Due pass appropriations. Call the members.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Nguyen, aye. Hall. Hall, aye. Mitchell. Mitchell, aye. Monning. Monning, aye. Nielsen. Pan.
Aye.
Pan, aye. Roth. Roth, aye. Wolk.
Currently at 7. We'll place that bill on call. We're in item number 14, SCR 17, palliative care.
All right. Thank you again, Mr. Chair, Senators. My final presentation today is on SCR 117. SCR 117 seeks to educate the legislature and to encourage the state of California to study the status and importance of coordinated palliative care and to develop solutions, tools, and best practices for providing better patient-centered care and information to individuals with chronic diseases in California. Palliative care is a team-based care provided by doctors, nurses, and a team of specialists who work with the patient's doctor. Specifically, palliative care focuses on relieving symptoms, pain, and stress of serious illness, improves quality of life for both patient and family, is provided by a team who works with the patients. Other doctors provide that extra layer of support, is appropriate at any age and at any stage, and can be provided along with curative treatment, and is coordinated and team-based. Palliative care provides us with an opportunity to defragment our healthcare system and improve the lives of those who suffer from serious illnesses such as cancer, the lives of those who care for them. It is important that we educate ourselves about healthcare options like palliative care. Today I have with me Adam Ogden from the American Cancer Society to answer any technical questions and provide testimony. Thank you.
Good afternoon, Chair and members. Autumn Ogden with the American Cancer Society Cancer Action Network, and we are proud to sponsor SCR 117 on palliative care. Dr. Pan did a great job, so I'm going to keep it brief. ACS CAN has been very big in supporting palliative care at the federal level and pushing through federal palliative care measure, which would provide additional funding for palliative care education across the nation, including here in California, as we realize that cost is a big part of pushing forward with palliative care. Recent studies indicate that by closely matching treatments with a patient's goals and improving their quality of life, palliative care can provide substantial cost reduction. We realize the state has done quite a bit here in California, but we feel that there's more that can be done. Costs and access to qualified palliative care and physicians are main barriers, but we believe that education about palliative care and creating a repository for information about it on the state level is also a critical component in ensuring patients are able to access the benefits they need. We would like the state to consider future legislation in this matter and respectfully ask for your aye vote.
Mr. Chair, members, Fred Notware, representing the Alliance for Catholic Healthcare, also in support. Thank you.
Thank you. Anyone else? Opposition? Questions? Comments? No questions or comments. We have a motion by Senator Roth. Would you like to close?
I respectfully ask for your aye vote. Thank you.
We have item number 14, SCR 117, PAN due pass appropriations. Call the members.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Nguyen, aye. Hall. Hall, aye. Mitchell. Mitchell, aye. Monning. Monning, aye. Nielsen. Pan.
Aye.
Pan, aye. Roth. Roth, aye. Wolk.
That's 7-0. We'll place that bill and call.
Thank you.
Thanks, Adam.
Apparently you and I missed it.